orbicularis oculi or orbicularis oris, those two sphincter muscles that close the eyes and close the mouth, are just embedded within the skin. And as that sphincter closes, it squeezes our eyes closed or closes our mouth. So to go into that depth in terms of that, then it's not that, there's not that much there. When you look at even the scalings, those are kind of important because of their, use in terms of both neck movement, so lateral movement, positioning of the neck, the cervical region, but as well from a respiratory point of view in terms of elevating or fixing the upper part of the rib cage for that forced inspiration. But it's, rib 1. So there's some pieces in there that there's a little more detail in the textbook about the attachments. But again, if you guys are really focusing on function and actions, then to go into the detail, and again, this isn't the detail that's in bigger books, but still going into detail on attachments, then if that's, kind of where you need to be, then that's fine backing away. So, okay. All right? Is there anything else? Okay. Yeah?
Sometimes I feel like the learning objectives are a little fuzzy. So sometimes it just says, like, discuss this.
Mm-hmm.
And so then I don't know how I should go about, like, discussing it to prepare for the exam.
Okay.
Or
Did you guys ever, I don't know what you got, how you guys, do you guys ever have to write learning objectives? So when you look at this, so describe versus locate versus define versus discuss versus list. And every learning objective from a teaching and learning point of view starts with a verb. Then there's a hierarchy of those verbs, which is called Bloom's taxonomy. And the higher they go, you go from list or identify up to analyze or something like that. And it asks you to do, make something a bit more detailed along the line. So if it's list and describe the origin and locations of major coronary arteries and veins. Basically that's saying, where does the aorta arise from? Where does the pulmonary vein arise from? Where do the pulmonary arteries arise from? That kind of thing. Where do they enter the heart? Basically it's just, here's this, here's where it is. That's simple. When it says discuss cardiac tamponade, well, cardiac tamponade you have to kind of sit there and say, okay, what do I know about the integrity of the pericardial sac? Pericardial sac is this dense connective tissue wrap, which is part of mediastinum, that has this outer dense connective tissue and this inner single layer epithelial lining that produces a serous fluid that lets the heart beat inside this dense capsule. Very much like a joint capsule. Because it's like that, it can't expand. So anytime there's extra fluid put into that pericardial space, then because the capsule can't expand, the heart has to compress. And therefore the heart can't beat as hard as it needs to be. And it starts to slow down and slow down. Cardiac tamponade usually referred to just being that there's bleeding in that pericardial sac. And because there's nowhere for the blood to go, it starts to squeeze the heart. It doesn't have to be blood, but that's usually the way it's defined. It can be an infectious fluid, something. But anything that causes excess fluid inside that dense connective tissue makes you go that direction. So the idea of that is, okay, what do we need to know about that? Do we need to describe the outer and inner layer of that, and then do we need to describe specifically in lecture versus in the blue boxes in the textbook, do we need to go through all of those? Is it enough in lecture to say, here is a restriction to the heart, and it's that fibrous capsule. So it's like in the lower extremity, if you have damage to the common fibular nerve, what are the functional losses that you're going to see if you test the integrity of muscle actions in across the foot? Pardon? Sure, but what's the function? What's the function of that? So if you tested a patient and they had weakened dorsiflexion but very strong eversion, have you damaged the common fibular nerve? No. You've damaged what? Just the deep, because superficial is still allowing those fibularis longus and brevis to work. So that's the thinking part of understanding what common fibular becomes deep and superficial, that kind of thing. So the learning objectives, in my mind, okay, this is my mind, give me a framework. And doesn't mean that I'm going to go through and say, okay, objective 1, this is what this is. Objective 2, objective 3. My expectation is that you use these learning objectives to sit there and say, if I didn't cover this in class, in specifics, in other words, I didn't go in and describe what cardiac tamponade was. If I didn't do it, could you do it? And if you couldn't, what do you need to do? What do you need to do to answer that, to fit that objective, to finish it and say, I understand this? If I didn't cover it in class, what do you need to do?
Read it and understand it.
Read it, look in the book for it. Can't find it in the book? What's your other resource? Me. So email me. You know? Because ultimately, the reality of it is to fit everything that in detail that's on these objectives in a 3-hour period within a week, or an hour and 15 minutes within, for all of these, has to be kind of, here's the umbrella pieces that we need to make these decisions, and then we need to go a little bit farther. Okay? And again, I'm the resource. The textbook's the resource, but I'm the resource. So if you can't find it, or if you want even just confirmation that you have found it, then either ask me in class, email me, whatever. Follow me home at night. You have to feed the horses first, but then I'm willing to answer the questions. I said you had to feed the horses first. So, okay? So I think from a point of view of going forward from now to the end of the class is, if you think about those learning objectives, I think you can kind of, if you try to think about them from the point of view of they're not going to be covered in the specifics necessarily. They might be, but in class, so what do I do with them at that point? When I walk away from here, what do I do with them? Okay? So are there any questions? More questions? Okay. All right, so let me do, because I took time to do this, I want to do a couple things, and not, so this might be my fault now, because I've had this discussion and I don't have time to finish this today. So what I want to do is I want to get you to a certain level of understanding in terms of orientation, so when we go into lab next week and I have one or two of the chest plates removed, we get a sense of what we're looking at, okay? And then we have a number of hearts that we've taken out of past cadavers and some lungs that we can look at and get a sense of what kind of the relationship of that is, the compartmentalization of the thorax into pleural cavities and into, the description is really mediastinum. It's not just the pericardial cavity, okay? So, and that's what this image looks like, and that's what I want to start with. All the mediastinum is a connective tissue compartmentalization that lies between the pleural cavities on either side. So there's nothing really in the pleural cavities other than the right and the left lung. But in the midline, there's this connective tissue compartmentalization that when you look at it in kind of this mid-sagittal look, it can kind of be divided off into a superior and inferior mediastinum. And the inferior is divided into anterior, middle, and posterior. The superior isn't. I mean, sometimes it is, but it isn't. And really, the only thing that's up in that kind of piece is the relationship of how the great vessels are leaving the middle part, or that middle part of the inferior mediastinum, okay? Because that's where the heart's located. The things that are located up here are the roots of the great vessels, and at some point early in life, the thymus gland was located up there, but as we age, the thymus gland disappears because all of our T cells are already produced and are now being replicated and used somewhere else in the body. So there's not that we're done making T cells for the most part. The anterior mediastinum is really not a lot in there. It's just a space that lies between the pericardial sac and the deep surface of the sternum. Okay? Now, when we look at the sternum, we look at this as the xiphoid process, and then we have the sternum, then there's the sternal angle, and from here up is the manubrium, and the manubrium is what's actually articulating with the clavicle in the first rib. Okay? And that's kind of just a landmark. That sternal angle is really just a landmark. Okay? You can kind of palpate it on yourself. You come up here, kind of the place between the two clavicles is called the jugular notch. And you can kind of go underneath that, and you can kind of feel where that articulation that we took off on some of the cadavers, you can feel where we broke that away, and that's kind of the inferior boundary of the clavicle. And then if you come down, kind of feel right here, kind of feel a dip. And that's that sternal angle. And that's really, when you look at the sternum, it's really made up of three compartments. And that's the interface between the manubrium and the sternum itself. Okay? Now, if we look at it more in kind of the compartmentalization of what it really should look like kind of thing, is that here we are looking at it parasagittally. So, and these are flipped to either side, just so you can see the root of the lung, like this. But the idea of the fact that this is all covered and obscured by connective tissue is that mediastinum, is that pericardial sac, which is that compartmentalization of the middle part of the inferior mediastinum. Okay? That's all it is. Okay? And then, on this one, you can see the relationship of, so here's our sternal angle, our great vessels come up above that, and as they come up above that, they then drop behind the heart, behind the pericardial sac, and now they're in this posterior part of the inferior mediastinum. Okay? And in that place is also where we see the bifurcation of the trachea into the primary bronchi, and we see the esophagus, as well as a bunch of nerves and vessels. Okay? If we look at it in kind of this transverse section, so here's the body of the sternum, the ribs coming off on either side, and you look at the positioning of the heart within that mediastinal cavity. So here, this yellow line, as we come all the way around, that's that connective tissue piece. And then the dark red line is going to be that visceral pleura for the lungs, so on either side. And then there's this recess that goes out, and then it becomes the parietal pleura out here. But then it becomes a part of the pericardium, really the capsule, the dense connective tissue that's surrounding the heart. Okay? So that's this yellow line. Then on the inside, we have the blue and the light, or purple, or whatever color that is. So this intermediate layer is really truly the fibrous pericardium, and then the light blue underneath there is a serous pericardium. And again, when we talked about the formation of a joint capsule, and we talked about that there's this outer layer of dense connective tissue, which is really the piece that sits there and is forming the integrity of the sac. Doesn't necessarily form the integrity or any of the stabilizing pieces of the joint, although in some instances it does. It's like the medial collateral ligament of the knee is a part of that capsule. So it does form one of those static constraints or one of those stabilizing pieces. But the other parts of it, just a dense connective tissue sac that's designed to hold fluid in. And that fluid is produced by this light blue layer, which is just a reflection of a different serous membrane. Serous membrane is just a single cell layer of epithelium that produces a fluid. And that fluid's designed, whether it's for this pericardial space or whether it's for this fluid space, is to just allow for a relatively frictionless method by which these structures can move around in there without being restricted. Okay? So as the lungs increase and decrease in their volume, the serous fluid out here allows for that lung to expand and contract without anchoring to the ribs. If it anchors to the ribs or scars to the ribs, then that's bad. And it's painful. Cause of when we talk about pleurisy, it's that irritation of those linings because that fluid isn't producing as frictionless of a surface as it needs to be. Same thing goes on the inside of this particular lining. That serous membrane reflects from the inside of the fibrous capsule to then lie on the top, intimately on the top of that heart. At that point, it's still a serous membrane. It's simple squamous epithelium, but it's now called the epicardium. So it's the outer part of the heart, the outer layer of the heart. Okay? So you see out here and in here, there's always this reflection of that serous membrane, so that there are two serous membranes opposing each other, which makes it really gives the ability for both sides to be producing that fluid to assure that there is this constant ability for those internal structures, the viscera, to move around in that cavity. Okay? And then at that reflection, this is where we get the vessels here in this transverse section. We get the pulmonary vessels going out either side, but we also have coming up this direction the aorta, we have the esophagus, we're below the trachea, so apparently we don't have bronchi here. But then we have some other vasculature and lymphatic ducts over here, okay? But again, if you look at that, there's always this lining. So this yellow lining is our mediastinum. And again, it's just a connective tissue separation. Okay? If we then look at the heart, without the lungs on it, so we're really, at this point, really just looking at that mediastinum, which is just this piece that's forming the pericardial sac. And then we have surface vessels, which have nothing to do with the heart itself, but they're really just serving the vasculature supply to the pericardial sac, to the inside of the ribs as the internal thoracic artery, and they're really just that. If we cut this open, the heart would lie right in here. And you can see along this line on this posterior wall, you can see this edge, which is just the area of reflection of that serous membrane, the serous membrane part of the pericardial sac, which would then reflect onto the heart. And because we cut the heart out by severing the great vessels, all we see is this area, this line where we've reflected them. Okay? So when we pull out the heart, when I pull out the heart and put it back in, what I will have done will have come in here in some fashion and opened this up and then pulled the heart up to the point that I could get to the base of it. So the base, this is the apex of the heart down here, the base of it, I can pull it up and identify how I want to sever the vessels that are leaving or entering the heart, but are attached to the heart. So how much of the pulmonary vessels do I want to leave so that we can see them going into and becoming a part of the root of the lung, or going through that hilus. Again, that hilus, that opening on the lung, is just where those vessels and the bronchi travel through. And again, it's very similar to this. It's just a reflection of that membrane that lines the lungs to then lining the thoracic cavity or the pleural cavities. Okay? Now, if we look at the heart, so when we pull these hearts out, what you're going to see is not anything that looks like that. Okay? Because that epicardium, or that serous membrane, that outermost membrane that lines the heart, is this connective tissue, this epithelium that lines it, and underneath it, deep to it, between that and the contractile elements, or the myocardium of the heart, is all of this fat. Okay? Now, the fact that there's fat in there tells us something. There's always a little bit of fat in the heart. But the less healthy that individual is, the chances are there's more and more fat in that heart. And it wedges itself between the epicardium, again, that simple squamous epithelium, and then the myocardium, or the contractile parts of the heart. Okay? And deep within, invested in that, are these coronary vessels. So you have a right and a left coronary artery. Okay? If you look on the posterior wall, here is the circumflex branch of the left coronary artery coming around to the backside. Here's the right kind of coming down and coming up here. Now the way these come, the right and the left send these circumflex branches around, it's always in this groove that lies between the atria So up here is the right atrium, and here's the right coronary artery going around. Here's the left coronary artery, and its circumflex branch going around. There's a groove there called the atrioventricular groove, or sulcus. And those coronary arteries, those circumflex branches, sweep around to the back side, following that groove, okay? And then once they're in the back, then they distribute themselves along different parts. Now in this case, what you see on this front is you have this primary branch coming down on the anterior side from the left coronary artery. And in anatomy textbooks, it's always called the anterior interventricular artery. And it's never called that in a cardiac textbook. It's called the left anterior descending artery, or LAD. But it's never called that in an anatomy textbook. It's always anterior interventricular. Okay? I'll get to what that means in a minute. The other side of this, from the right coronary artery, that circumflex branch goes around, and now we're behind the heart. So this orangish look here, and comes down as a posterior interventricular artery. Here you see it right here. Okay? Now, when we look at this, let's not worry too much about this. If we look at this is kind of a cross section of the heart through the ventricular system. So this dashed line right here. So we're below the atria, and what we're looking at, sternocostal, or that anterior surface out here, here's our posterior surface that's now really lying down on the diaphragm. Okay? So when we talk about kind of anterior, posterior of the heart, it's really the anterior sternocostal surface, and it kind of anchors out like this, so that the right or front part of it's kind of curved upward, and then the posterior part is lying more inferiorly and lying down on the diaphragm. Okay? And that's why they're calling it sternocostal versus diaphragmatic surfaces. But if we just think about it from a point of easier way, just to think anterior and posterior, okay? And relationship to posterior interventricular and anterior interventricular arteries. And what you see is that this whole area, so here's our left ventricle right here, and here's our right ventricle. The left ventricle and the interventricular septum are getting their blood supply from the left coronary artery, whether it's anterior interventricular that would lie right up here, whether it's circumflex and marginal branches that kind of sweep around off of that as it comes around to the backside. And then the right coronary artery is giving its blood supply to the wall of the right ventricle and then back to just the back part of that interventricular septum. And the critical part of that is this little yellow dot in the middle, which is the atrioventricular bundle. When we look at this picture up above, the gold color is our left coronary artery, and the right is the red is our right coronary artery. And then this yellow line is our conducting system that's coming out of that atrioventricular node to then descend through the interventricular foramen or interventricular septum right here to then branch out, and it's not showing the branching here, but it branches out and then serves the ventricular wall. Okay? So the critical piece here then is that damage to this anterior interventricular artery or left anterior descending artery, blockage of that will destroy or will affect the conducting system of the heart. Okay? Now, I'm going to come back to that. I want to show you these angiograms. So here's an angiogram where you can kind of see this line right here is the catheter that was placed in a cath lab to then put a radiopaque dye in there. And what you notice is here is the right coronary artery, a normal right coronary artery, circumflex branch coming around. This is the marginal branch down here. But you can see that it is relatively complete in terms of its filling. And then you come over to this one, and you can see a narrowing right there and a narrowing way up there. And what that amounts to is that atherosclerosis, or some sort of impingement within that right coronary artery. And then what you notice in that narrowing, and now this is a picture post-stent placage or angioplasty, and these lines are kind of showing the positioning of the stent that got the 99% blockage up above, and then this stent showing opening up of the 95% blockage that's on the circumflex part right here. Okay? So it's before and after stent placement within that cath lab. Okay? Now, here's a picture of the left coronary artery. Again, here's this shadow is the catheter. Here's left coronary artery, and here is the left anterior descending artery coming down. Here is the circumflex going around to the posterior side. Okay? And then cardiologists have a bunch of other names for some of these others. But really what you should need to look at is really this one coming down, because this is the one that's serving that interventricular foramen and getting the majority of it throughout the kind of the anterior posterior dimension of the heart. Here what you notice is here's a left anterior descending, and you see this really cloudy spot right up here. Okay? This is a position of a previous stent. And then down here you see kind of a truncated vessel right here. And this is the presence of a previous stent as well that closed off and didn't remain open. But the fact that this one up here, this clot is forming at the proximal end of a previously placed stent. Now you go in and place another stent in there that overlaps that, and now you see that cloudy place is no longer there. You still see this blockage. That blockage is there and is permanent. But now you see how the cloudy piece is gone, and now there's blood flow throughout again. This darkened area is just the way the radiopaque dye shows up depending upon the orientation of the vessel. It's nothing good, bad, or indifferent. Okay? So if we go back up to this thing, well, let's go back up one more. So we look at the relationship of the coronary arteries coming off the left side and the right side of that aorta. Okay? So now we take and we cut that aorta and we look into it, and here we see the three cusps of that aortic valve. And we see in terms of the position of the left and right valve and the opening to those two coronary arteries, that they lie behind within the sinus of each one of those valves. And you look at this posterior valve, there's no artery in there. Okay? But now think about the fact that if we have the vasculature, if the ventricle, left ventricle is pumping and pushes blood up, then these cusps are going to slide open, and they're going to obscure the opening of those coronary vessels. So during ventricular contraction, the flow bypasses the coronary circulation. And as soon as that ventricle starts to relax, and the elasticity of the aorta starts to compress and force the liquid, the blood in both directions, that blood comes down and starts to push into these sinuses and then passively closes these valves. And as they do that, the circulation, the turbulence occurring in this sinus of each one of these valves, the left and right valve, is what ultimately forces blood into that coronary circulation. So coronary circulation is actually taking place during diastole and not during systole, where the systemic circulation is getting its circulation pushed through during systole and not diastole. Okay? Now, there is because the heart, as a muscle itself, it's got its own venous system as well. And so, paralleling the vessels, so here we are on the anterior wall, kind of the translucent light colored blue is everything posteriorly, but on the anterior side we have this great cardiac vein that's paralleling anterior interventricular, or LAD, and it ultimately sweeps around, again, within that atrioventricular sulcus. And when it comes around to the back, it begins to expand and pick up other veins, left marginal, middle cardiac vein, which is traveling with the posterior interventricular, but they ultimately drain into this large, kind of loose-walled vein called the coronary sinus. And the coronary sinus ultimately empties into the right atrium along with the superior and inferior vena cava. Okay? So in this instance, what we're looking at, here we've got that right atrium opened up. Okay? So here's our superior vena cava. So the superior vena cava is getting everything from our upper extremities, our head and neck. So brachiocephalic veins on both sides draining into that. Internal jugular veins draining into the brachiocephalic veins on both sides. So everything's coming down from the head, everything that's coming from our limbs, ultimately all of those veins fuse to form this superior vena cava, and it drops the blood into this right atrium. Down here, the inferior vena cava coming up from the abdomen and getting the hepatic vein coming out of the liver is draining everything from below and coming into the inferior part of the right atrium. And then, if we look right here, just above the inferior vena cava, is the opening for the coronary sinus. So now we have the venous blood coming in from the heart. Okay? I think I'm going to stop there, just because that gives us kind of the venous stuff, and then when we start next week on Monday, what we'll see, we'll go through this and we'll come and add some more stuff to it, and I'll try to put it together with kind of the rest of the thoracic cage before we move on to the abdomen. Okay? All right. You guys have any questions? Okay, so this afternoon, 1:30, I don't care who comes, about 9 of you. And then 2:30 the next half. Okay? And it'd be like the same. So